Okay, hi students. This week we're going to be talking about strokes. This is chapter 67 in your textbook. And I have to apologize for chapter 66. I'm not sure what happened. I think I had my telephoto lens on when I was recording. So it's really close. And I didn't realize that until I went to upload it to my computer. So I apologize. All the information's there. It's just a little close. So I've double checked to fix that problem. So this week we're going to talk about strokes. So if you haven't watched chapter 6 or listened to chapter 66, I really need you to do that, because a lot of what I'm talking about is going to continue on with what we do if somebody has increased intracranial pressure, what cerebral perfusion pressure is, those kinds of trauma things that are going on in the brain. You need to know how to assess that. How do you know when it's getting bad? Different levels of consciousness, those sort of things. They're really important, because now we're going to take that information, we're going to start applying it to different things. And this week we're going to talk specifically about strokes. And in the medical world we call that cerebral vascular accidents, CVA. And well, we'll just start from there. So strokes are a really common healthcare problem in the United States, third leading cause of death. And a very serious reason for people that have long-term disabilities. So if you end up working in home health care or a long-term care facility, a lot of the patients that are in there because they have suffered a stroke and have long-term, very serious debilitating effects. So one thing we want to do with strokes is prevent it from happening in the first place. Once it does happen, we want to minimize damage. So we're going to talk a little bit more about that. Okay, so there's some mortality with it, like that previous slide said, about 25% within 1 year. So you can see in the acute phase that, you know, most people will survive, but there are, because of the consequences of that, the patients can actually end up, it's fatal in 25% of the cases. So the first thing we want to do is identify our patients who have risk factors, because obviously we want to prevent it in the first place. This is when teaching becomes so important. Community education, health education, because if we can teach the public some risk factors and get them to alter lifestyle, sometimes we can prevent this really debilitating disease. Risk factors are divided into modifiable and non-modifiable risk factors. Obviously your non-modifiable ones are things that we can do absolutely nothing about as a nurse. As people age, they tend to be more likely to develop strokes. Men have more strokes than women tend to. There are more strokes in the African American community, and if you have a heredity or family history of stroke, you are more likely to develop have a stroke yourself or your patients. Now, the things that we really want to focus on as a nurse are those things that are modifiable. So, number one, if your patient has hypertension, we want to treat that and have your patient not have hypertension. Hypertension is one of the leading causes of hemorrhagic stroke. We'll talk a little bit more about the differences between hemorrhagic and ischemic stroke. Metabolic syndrome. We'll talk more about this during GI week. Patients who carry a lot of weight in their middle portions, who are pre-diabetic, have hypertension, things like that, leading to metabolic syndrome, much higher risk for developing stroke. Heart disease, especially if your patient has increased cholesterol, especially the bad cholesterol, high LDLs, with a bad ratio, high LDLs to low HDLs, patients very high risk. Or if they have atherosclerosis in the coronary arteries. Another leading risk factor with heart disease is AFib, a flutter, like we've talked about last semester in MedSearch 1, because that can create clots, and then the patient is at risk because they've got developed clots. People who drink a lot of alcohol, people who have a diet high in fat, high cholesterol, not a lot of fruits and vegetables, low fiber, poor diet, that can lead to stroke. Drug abuse, especially cocaine. Cocaine is a very, very potent vasoconstrictor, and what they're finding is even if cocaine use has started earlier in life and then stopped, they're still at a much higher risk later on in life for developing stroke. So that the drug abuse should go in your history, like when you're doing your intake assessment. That's why some of these questions are so important, because if your patient starts answering yes to some of these questions, you need to start thinking this person could be a little bit of a higher stroke risk than someone who doesn't answer yes to some of these. People who have sleep apnea, this is a huge problem in our population, and it's actually on the rise. And sleep apnea, alcohol, and metabolic syndrome tend to go hand in hand, because the heavier your patients are, obesity will also, those patients are also more likely to have sleep apnea. Obviously obesity, we just talked about that. People who are not working out, they're your couch potatoes, higher risk for stroke, and obviously smoking. So basically any bad thing, any bad lifestyle choices can increase that patient's risk for developing a stroke. So you want to teach them that, and then teach them how to prevent that, because obviously nobody wants a stroke. There is a difference between a CVA, a stroke, and a TIA. A TIA is a transient ischemic attack, a TIA. And if you'll remember from MedSurg 1 when we talked about angina, and you remember that angina is a temporary ischemia to the coronary muscles, where there's inadequate blood supply and inadequate oxygen for just a small amount of time, a transient amount of time. And then those vessels open up and then the blood flow can return. It is a precursor for an MI, but it's not a full MI because there's no cell death. That's what a TIA is in the brain. So a TIA, transient ischemic attack, can cause some temporary neurological symptoms like facial paralysis, numbness, tingling, a little bit of forgetfulness, things like that, but it usually only lasts, less than 3 minutes, and then there's full restoration of patients' neurofunctioning. Those patients are at high risk for full-blown stroke, although there's no cellular death in the brain, but you do need to keep an eye on those patients. And we're going to talk about how to identify them and maybe some things that we can do to prevent the full-blown stroke. Okay, did I say 3 minutes? I meant 3 hours. I think I said minutes. But usually they resolve within 3 hours, although we start getting nervous about that. We'll tell you about that in a second. Okay, so let's talk about stroke. What are the different kinds of stroke? There's 2 kinds of stroke, and it is extremely important that you know the difference between the 2. One is hemorrhagic, this is bleeding, and this is embolic, or sometimes you'll see it called thromboembolic. This is bleeding, this is a clot. So we're going to keep those 2 things in mind because the treatment is very, very different. Both of them will cause ischemia, inadequate blood flow, but a stroke, a full-blown stroke, is when there's ischemia to the part of the brain and actual brain death, parts of the brain cells, not brain death, that's a different thing. Death of the brain cells in a certain area will start occurring, and there's a difference between an evolving stroke, that is a stroke that is currently initiating, and a complete stroke, a stroke that is done. And this can occur up to about 3 hours. So if you recognize the symptoms and you see a patient starting to have some signs and symptoms of a stroke, and I'm going to tell you kind of what some of those things are to look for, it is ideal if you can intervene here. Sometimes people, especially if it comes on slower or they don't get to the hospital right away, and it has the symptoms have been occurring for 5, 6, 7 hours, that stroke may have been complete. And at that point, we're going to do some different interventions. So this is what a normal brain looks like. Sorry, get rid of that. This is a normal CT scan, and I showed you a little bit about this in chapter 66, but I just wanted to go over it again. When they do CAT scans, they will take images of this, and the surgeon or neurologist will indicate how far apart they want these slices, and it could be like, like 1 centimeter apart, like 3 centimeters apart. And what they'll do is then they'll just slice all the way down through the brain like that, and then you'll just get different images. And so like for example, this image right here would correlate to this. This is a normal looking CT scan. You've got your fisiform right here in the middle. You've got normal looking ventricles, these frontal ventricles, which are right about here, look a little bit like a butterfly. Both sides of the brain look fairly mirror image of each other. These in here are just more normal looking ventricles, completely normal. This is a really healthy looking brain. I just want to show you that because I'm going to show you some scans that don't look as healthy. So what is actually occurring when a patient is having a stroke? The blood flow that is getting to the brain is completely interrupted. And what happens is that the neurological metabolism will start getting altered inside of 30 seconds. Your brain needs oxygen all the time. And when it's deprived of for even just a few seconds, that neurological metabolism will start getting altered. Within 2 minutes, the metabolism will completely stop, and cellular death can occur within 5 minutes, which is why it's so essential that we start preventing this from occurring in the first place. The next step, once you're identifying that a patient is having a stroke, is to diagnose it very quickly. And the first thing that you want to do, so when your patient is coming in, is to recognize that the patient's having a stroke. And recently, in the last several years, we've gotten a lot better about identifying strokes in the community. There's a lot of public information now about the signs and symptoms of a stroke, what to do if you think that your loved one is having a stroke. You call 911, and then the paramedics who will come out, they are also equipped with like stroke protocols. They will call ahead to the ER and say, you know, we're bringing somebody in with a suspected stroke, and they will get that person to a CAT scan immediately. So your role as a nurse, number one, ABCs, you know, make sure your patient's breathing, get a set of vital signs, and get them to CAT scan immediately. These CAT scans are usually done without contrast. The only reason being, contrast requires you to start an IV, and contrast gets injected, and that takes too long. So you just throw them to CAT scan without getting the contrast in, because what you're looking for is it an ischemic stroke or is it a hemorrhagic stroke? And it is really important that you find out the differences, and the differences will show up on CAT scan. I'm going to show you what that looks like. So if you're out in the field, if you're working with paramedics, if you're working in the ER, some signs and symptoms of a hemorrhagic stroke, and these are just guesses because you can't know for sure until you get a CAT scan, but some suggestions that it's probably hemorrhagic versus ischemic. And I will tell you that 10 to 20% are hemorrhagic, and 75 to 80% are ischemic. So most of the time it's ischemic, but sometimes it's hemorrhagic. And the signs and symptoms that it's hemorrhagic is a sudden headache, a very rapid, grabbing my head. This is the worst headache of my life. I just, I can't move. I can't, it hurts really bad, because there's bleeding in the brain, and the bleeding has pushed a ton of pressure on the brain. And you remember I told you that the intracranial pressure does not have a lot of place to go. Well, all of a sudden, if you just put a bunch of blood in the cranial vault, that's going to be a lot of extra pressure. So the patients will constantly, the worst headache in my life. So that's one thing. They might start vomiting because with increased intracranial pressure, and remember that's going to be greater than 15, patients can start vomiting. It's pretty common for the patient to start having seizures, and it's often associated with patients who have had an aneurysm, patients who have had known hypertension, and sometimes trauma. Trauma will cause bleeding in the brain, and the results are the same, but it's not technically a stroke. It's really more of like an intracranial bleed, because like a patient who gets hit in the head or has like a contra-coup injury where there's some shearing of those vessels, it can cause bleeding in the brain, and that can lead to a subarachnoid hemorrhage or an intracerebral hemorrhage. remember from chapter 66, I told you to remember about the dura and the subdural, that kind of thing. So you can get some bleeding in there, and it acts like a hemorrhagic stroke, but there's a cause to it, the cause being trauma that severed the artery, whereas like the aneurysm and hypertension was the artery itself malfunctioned, but the results are the same. I hope I made that clear. So, but for patients who have had a thromboembolic stroke, meaning a clot in the artery, those symptoms tend to be more, the patient might get flaccid on one side, they can't use a certain limb, they might get confused, they might have slurring of the words, slurring of their, slurring their words, they can have facial drooping, they might be unable to speak all of a sudden, they might be able to not understand what you're saying, garbled words, things like that. They don't typically complain of such a bad headache, they don't typically throw up, and it's really especially noticeable on one side versus another, like all of a sudden they'll droop their arm or something like that. So these two are quick guesses. This one is confirmatory about what you've got going on. So these two on this side are example of thromboembolic strokes, no bleeding, and this one is a hemorrhagic stroke. So what happens here, basically a thrombus is a clot that is broken off because of atherosclerosis. Like remember when we talked about in, I think it was Med-Surg 1, with the plaque buildup, like the atherosclerosis in the coronary arteries, it builds up, and then this becomes inflamed, and it kind of bleeds and develops a scab. Well, then that breaks off, and that's called a thrombus, and that is arterial. Remember, now this is arterial, so this is all after the left side of the heart, and it's in an artery, and it breaks off and it travels up that artery. That's called a thrombus. An embolus it does the same thing, but it's usually a piece of debris. Like when we talked about orthopedic week, you could have a fat embolus, you could have a little piece of fat that's floating in the arteries. You could have clots that are coming out of the left side of the heart, like your patients who are in AFib or AFlutter can have a little clot. So basically it's the same thing, and oftentimes you'll hear people lumping them together, calling them thromboembolic strokes, but technically you could have a thrombotic stroke or an embolic stroke, but that is kind of like, for our purposes, you don't need to know that. It's basically you just got something jammed in the artery. The hemorrhagic stroke, there's not a clot in there. It's just the artery has ruptured, either from an aneurysm, hypertension, trauma, and now the blood that is supposed to be going up into these areas of the brain are going like into the brain tissue itself. Both of these kinds of stroke cause ischemia. So the parts of the brain that are up here waiting for oxygen aren't getting the oxygen because of a problem down here. That's really what's going on, is ischemia in the parts of the brain that are waiting for the blood's not getting there. One because it's clotted, and the other one just because there's a break in the vessel. Okay, so let's first talk about hemorrhagic strokes. These are less common, but often more fatal. The specific kinds, like the subarachnoids, the intracerebral bleeds, those are they fill they fill space with blood where there's not supposed to be blood. It's outside of the vessels, and it's oftentimes caused by an aneurysm. There is a structure of arteries in the brain that you'll probably remember from physiology or anatomy. It's called the circle of Willis. Now this is looking up underneath the brain. So if you're standing up and looking at somebody like that, this is how that is looking. Oops, put this out, hang on. Okay, so this is going up on either side of the brain. You've got these arteries coming up and they're branching off of these carotid arteries right here. So you got your carotid arteries coming up and then they're branching off and they come up through the circle of Willis, and then you've got these main feeders that go to all areas of the brain. You don't need to memorize exactly what these arteries are, but it is, if you end up working in neurosurgery, you will need to know what your anterior communicating, your middle cerebral artery, because where the aneurysm is or where the rupture is totally going to matter how your patient is responding. So obviously, if you're going to, if an artery ruptures down here in the basal artery, this is your cerebellum. It is responsible for movement and coordination. You're going to see problems with movement and coordination because that's where the damage is. If it happens, up here in the anterior communicating, some of the middle cerebrals up here, you're going to have problems in your frontal lobe, problems with emotion and learning abilities, cognition, things like that. So this is where the problem occurs when you've got a hemorrhagic stroke. These are different kinds of aneurysms, and basically what an aneurysm is, it's in the artery, always in the artery. And you can have a saccular aneurysm, which is just like a little balloon, or a physiform aneurysm, which is just like an outpouching in the artery, and this is just very weak, and so is this. It's like a garden hose that has a bleb in it, and then one day you turn that water faucet on and because the pressure just gotten too much. So there's actually a fairly high percent of people in the United States that just are born with aneurysms. Many of them live their whole life and never know that they have it. It is, never ruptures. But when it does rupture, it's often deadly. It is very, very difficult to treat. Best case scenario is that it just has a slow leak and the patient comes in with worst headache of my life. We can get an angiogram, meaning we run contrast up into the brain, just like we would if somebody we suspect they're having a heart attack. We run contrast to find out what coronary arteries is blocked. We can do the same thing in the brain, run contrast up into the brain and find out what artery is damaged, and then we can fix it. So best case scenario is a slow leak rather than a big rupture, because big ruptures are usually fatal. This is repeat. You should remember this from chapter 66. If not, go back and study it. It's just the different areas of the brain that can get affected with a bleed. This is what a CT scan of a person who has a bleed, a hemorrhagic stroke, looks like. Again, this is our normal CT scan over here. You've got your normal ventricles. Your midline is exactly centered, and both sides are looking fairly mirror image. Now this is an example of a hemorrhagic stroke. You can see all this area in here has blood in it. You can also see your midline is got some significant shifting here. This ventricle is extremely enlarged. This patient is in really bad shape. Here's another example of a CT scan, and all of this is blood in here. You can see that you've got some shifting here, so you've already got some swelling and inflammation going on. And then obviously post-mortem, this is what it looks like. These are actual autopsies. Obviously we can't get this picture when somebody's alive, but you can see all this bleeding in here. See how all this red, see how the brain is supposed to look like this, and this is red in here, and this is a slice this way, not this way, and this is back to slice this way, and you can see a huge hematoma right here. You can see shifting in that midline. See, that's shifted here. Obviously, this person did not make it. This is a significant injury. So if we can get to an aneurysm, if we do an angiogram, find out that somebody has an aneurysm that hopefully has a slow leak, sometimes we can fix it. We can go in and clip the aneurysm. The neurosurgeon goes in, opens up the brain, and can put that clip on there. Another thing they can do sometimes is they can go up through the femoral arteries or the radial arteries, or up through the carotid arteries, find out which one of those arteries up through the circle of Willis is affected, put a coil in it. What happens there is that all the blood that is in there will clot and develop a clot, and then that makes us significantly tougher. So now any pressure up in there is not likely to make that thing rupture. Sometimes what they can do is, these are just other kinds of, like this is just a spring. This is another kind of coil that they can go up there and just put a little coil in the aneurysm. They can also wrap them. So with the Berry or saccular aneurysm, they can put the clips on. But with the fusiform aneurysm, they have like a biological or synthetic wrap that is kind of like putting an ACE wrap around it, just gives that some support. They do this in your more major arteries that if that blows, it would be catastrophic, so they can go in and wrap that. So those are some things if they can identify ahead of time that somebody has an aneurysm, those are some ways to fix it. And then obviously, like if somebody has hypertension or something, if we can get the blood pressure under control, which is why we get so nervous when people's blood pressure starts getting so high, because those arteries in the cranial cavity they're delicate, they're small, and so if they're exposed to high levels of pressure for a long time, they can rupture. So your hypertensive patients have the same kind of risk as somebody who's walking around with an aneurysm who's got a weakness in the artery because of the aneurysm. Your ischemic strokes or an embolic stroke, whatever, this is a little bit inaccurate, because ischemic, they're all ischemic. Ischemia just means lack of oxygen. And the hemorrhagic strokes also, it's a lack of oxygen because the blood can't get to where it's supposed to go. So are the embolic strokes. So both embolic and hemorrhagic strokes lead to ischemia. So just ignore that word right there. So we're just going to focus on embolic strokes. It does lead to ischemia. This is ischemia. This is another example of a brain that has suffered a stroke. This one is not horrible, although this is a pretty good size stroke, fairly significant. Patient's probably going to have some deficits with this, but you can see here's your midline, and this is up a little bit higher in the brain because you can't see the ventricles yet. Those are a little bit down lower. It's a little bit up higher in the brain, and the midline is fairly central. So this is not horrible, but it's identifiable here that your patient has suffered an embolic stroke. There's ischemia, but there's nothing else there. There's no blood that would have been caused like from hypertension or an aneurysm. This is just cell death from lack of oxygen because of an embolus. Okay. Now, how do we treat ischemia? First thing we're going to get that CT scan like I already said. Now, if we find out that there's not a hemorrhage, we find out that it's an ischemic stroke, now we know for sure there's either a clot, for sure there is a clot, it's either a thrombus or an embolus. Nobody really cares what it is at that point, we just have to open it back up, because the sooner that we can open it up, then we can restore oxygen to that part of the brain. So what we do is we give TPA. TPA is a very potent fibrinolytic agent. By fibrinolytic, I mean it eats away at a clot or at an embolus that is there. So it is a drug called TPA. However, there are massive side effects. You've got to be really careful. So there's some specific criteria that we have to follow when we're giving TPA. You need to know these. So before you can give somebody TPA, they need to be over 18. The reason is I don't think it's been studied in people younger than 18, or FDA has not approved it for people that are younger than 18. Most people who are younger than 18 don't have ischemic strokes anyways. This tend to occur by ischemic stroke, I mean thromboembolic strokes. I keep saying that wrong. As a person ages, they tend to have a higher likelihood to develop thrombotic embolic stroke.